Good afternoon. Welcome to Medical Grand Rounds. I'm David Schwartz, Chair of Medicine. It's a pleasure to have you all join us. When you have questions, please put them in the Q&A box. I will moderate the questions at the end and try to get to all of your questions with Dr. Franco-Paredes. Dr. Franco-Paredes is an associate professor of medicine in our Division of Infectious Diseases here at the University of Colorado. Dr. Franco-Paredes received his MD degree from La Salle University, a School of Medicine in Mexico City. He did his house staff training, fellowship training, and also chief residency at Emory University. He also trained as a Fogarty Fellow at the Rollins School of Public Health and focused on AIDS research and HIV needs in the community. He was recruited to Emory as a faculty member and served as a faculty member there between 2004 and 2011, and then entered into a community-based practice for 6 years. We were very fortunate to recruit him here to the University of Colorado in 2017 as an associate professor of medicine. He's proven himself to be an outstanding clinician educator, has received a number of awards for that, and importantly, has provided a substantial bridge between our university, our infectious disease program, and the community and real needs and issues in the community. He's focused his research on prison populations and health inequities among prisoners. Today is going to tell us about racism and health inequities in the COVID-19 era. Welcome, Dr. Franco-Paredes.
Thank you, David, for the kind introduction, and thank you for the opportunity to speak today. I also want to thank Eric Peshla, my division director, who has always been very supportive for these efforts that you mentioned, linking our campus basically with the community from the infectious disease perspective. So to start the presentation, I would like to mention that I came to this realization that racism and health inequities in many ways is not like I took a course or I learned it on a textbook, but it was more from honestly my observations in clinical practice, but also by initially being in collaboration with my colleagues at the Denver Health Human Rights Clinic here, particularly Janine Young, Jamie Young, Mu, Trina Seefeld, Michelle Haas, and then individuals like Hillary Don Levy here at the university, and Martin Kershak as well. So the reason I mentioned these is because I would like to at least start by explaining this journey into this understanding by these observations in a community, as well as you presented, David, some of the activities in immigration detention centers, as well as the correctional facilities, particularly since last year and more during the ongoing pandemic. So the idea is to also bring together today, or to talk about how the COVID-19 pandemic has really, in a way, increased our awareness of some of these important differences in health outcomes that some ethnic or racial groups experience based on the social determinants of health, including racism. Also, I wanted to tell the story just briefly that last year during the Tropical Medicine Conference, I had the opportunity to go to the Washington Holocaust Museum. And one of the things that struck, that was, something that really changed my view of many things was visiting the museum memorial. And then after, going with my colleague Andres, and now in the division, when you walk at the end, there's a big sign that says, so now that you learn these, what would you do next time you see injustices? So it really stuck with me, and I think it's important to say that sometimes we realize that some of the patients that we see is just part of the symptoms of a larger social situation or very complex social factors that lead to them and then ending up in the hospital or in the clinic and having to deal with these factors, which again is crucial because to understand that the epidemiology of some of these infections or some of these diseases is related to whatever happens in society. We need to understand society to be able to understand these diseases, and that was basically the key message I would like to talk to you today is again this journey, as well as using some cases for illustrating these concepts. So the outline is just to do a brief introduction about health equity, health inequalities, social justice, as well as structural racism, and then just 3 cases to illustrate these concepts or bring a discussion of some of the different populations and these larger social factors that lead to having poor health. And some, at the end of this discussion, hopefully we can, I can present to you some potential ideas from the literature and from observations that we can potentially implement or continue to implement in our communities. So to start with the introduction on COVID-19, we know at this point what is being presented even in previous grand rounds, and I'm not going to go into more detail except to say that the rate of hospitalization or the rate of infection, hospitalization, and death has definitely disproportionately affected some particular minority groups, including African Americans and Latinos, as well as American Indians. And this is, could be explained from different perspectives, but one of the important issues to emphasize here is the, that this is essentially, at least from the risk of infection and hospitalization, and even having a complicated course determined largely by social factors in the community, including living conditions such as residential segregation, living in densely populated areas, sometimes living far away from communities. And this is not necessarily here in Denver, but this applies to rural settings mostly, and having multi-generational households where, one of the elderly, the grandmother, the grandfather becomes infected from a younger member and have complications from that. And then also the fact that these minorities also are overrepresented in jails and prisons, as well as immigration detention centers. Work circumstances, people that have to work every day, not having income protection in terms of, if you don't work, you basically may be able to not pay the rent, and therefore comes the issue of housing insecurity, food insecurity, be able to provide a meal for that day for your family. People that do day laborers, and also other aspects include, underlying health conditions. These communities tend to have a high prevalence of some of these conditions associated with, having, poor diets, lack of, access to medical care, or underinsured populations, and also, the stigma associated, for example, with the immigrant community, particularly undocumented, with the public charge, where if you're trying to become a legal or documented citizen or resident, and you are using, Medicaid or any government-funded assistance, that may impair your ability to be able to obtain this process or go through this process in a way that you're able to achieve it successfully, and therefore people tend to not seek medical care because of this. And we know that that's an important factor in the Hispanic Latinx community. So now we come to this question, and this is a participant. So I will ask you to also see if you could answer whatever is your option. So here is the question is, what is the difference between health inequities and health inequalities? And option A is inequity and inequality can be used interchangeably. The second option, or option B, is inequity refers to unfair, unavoidable differences in health, arising from poor governance, corruption, or cultural exclusion, while inequality refers to the uneven distribution of health or health resources. Option C is inequity refers to lack of financial resources and inequalities due to a lack of access to care. Options A and C are correct, or the last option is none of the above. So if you would like to participate in the poll, just click your option and we'll see what the results are. And we'll wait for the results to comment on them. Can't vote. Okay, so thank you. I got the results, and 92% answer the question, which is correct. Which is basically the result is option B. Inequity refers to these basically adding a moral dimension to the inequalities. Just to move on, because we'll talk about this next. So here, this diagram is basically to talk about the overall concept of social justice as a theoretical framework of justice in the community or the communities in terms of the distribution of wealth, opportunities and privileges within a society. So if you take this framework, basically a big component of this diagram is the concept of health equity. So it's a significant component of being able to achieve or to have social justice to have health equity. So in this sense, how do we define health equity, or better, how do we define health inequities? Is basically the unfair, unjust, and avoidable differences in health and health outcomes. So here is basically does not refer to, for example, just to give a more clear example here, is healthcare access, healthcare delivery. That, if there's a different type of health access or healthcare delivery among different groups, that is a inequality. That's a quantitative aspect. However, if you talk about these within the concept of social justice or these fair societal arrangements, then you will call that a health inequity. And as you can see here, health equity is a very important domain of social justice, but there are other factors which I included only here, housing equity and education equity. And at the same time, obviously, education equity, just to pinpoint one, big one, is a component of health equity. So they're all interrelated, interconnected domains of social justice that are crucial. But by far, health equity is very, very important. And it has to do also with the ability to achieve this. Is not only just health, just to have health, but it's health to identify yourself or your community as in terms of well-being. This is a second question, so we'll do the same exercise as the first question. And here's the poll: is what is your understanding of the concept of structural racism? And option A is it refers to white supremacy led by the KKK. B, individuals with negative normative beliefs, stereotypes, and attitudes, prejudice towards racial groups. Option C is racist attitudes towards particular cultures. Option D refers to the inequities perpetuated by social, economic, and political systems that results in systemic variation in opportunity according to race or ethnic background. And then option E is none of the above. So if you will please choose one of the options, and then we'll talk about the results. So we have the results back, and so 96% refer with a correct answer, which is basically, again, here we're trying to connect or to explain structural racism. And these are basically, the best answer is inequities perpetuated by social, economic, and political systems that results in systemic variation in opportunity according to race and ethnic background. So now that we talked about this, and we'll talk in more detail in a few minutes, how do we, basically as the title of this presentation talks or speaks of, is how do we connect racism to health? What's the impact of racism in health within this framework of the social determinants of health? So racism in the US, and this, obviously applies to all countries, but here we're trying to focus basically this definition or adapt this definition to the US. And the concept of race is important to explain that it's not a biological concept. It's a racial, a social category based on nationality, ethnicity, phenotypic or other markers of social difference, which actually captures access to power and resources in society. And therefore, a way to define racism by different, publications in sociology, as well as in human rights and other domains, is an organized social system in which the dominant racial group, based on an ideology of inferiority, categorizes and ranks people into races or groups defined as races, and uses its power to devalue, disempower, and differentially allocate societal resources and opportunities to groups defined as inferior. So the three domains of racism in this sense are the structural, which we'll talk in a second, cultural, and individual level discrimination. And the three of them have an impact on health. However, all the literature consistently demonstrate that the most important determinant of health inequities, now that we're going to try to focus on health inequities or the impact of structural racism or racism in general, is structural racism is by far the major contributor of these racism into the health and health outcomes of a particular race or group. So structural racism, as we talked about, in a different way, is these processes or institutions, these structures could be political, economic, social, that provides some advantage to a particular group and differentially oppress the other group or groups. And basically, in this case, now we're moving towards reaching, this connection between race or racism or structural racism specifically, and racial inequities in health. And this is basically has to do with risk, opportunities, and resources to be able to achieve health. So some examples to bring this concept into everyday realities for many people, and what I think is the goal of this presentation is to talk about, for example, racial residential segregation, discriminatory incarceration, healthcare quality, and the access to healthcare. So the best example, maybe the most studied among these social phenomena, is racial residential segregation. So in 1934, the Federal Housing Administration decided that to support housing projects in the urban settings, they defined these maps that I called using these different colors. And the red lines were those that were allocated for African-American communities living in urban settings. So here is this picture of this old housing project in Detroit, the Brewster Douglas Towers that were demolished in 2003. However, basically the idea here was to keep these populations separate from white communities. And, again, this is 1934. So, there's the Civil Rights Act of 1964 is not there yet, and so on. But there are, again, different movements to be able to enter into the civil rights era. So the connection, how's racial residential segregation, which continues even to today, affects health, is basically by concentrating risk factors into the community. So higher levels of violence and crime, higher levels of poverty and low quality schools, the presence of environmental pollutants that can predispose you to develop cancer. I think one of the most, or the ones that we work, for example, at Grady Hospital in Atlanta, we know that the HIV/AIDS is highly concentrated into the urban, inner city, urban minority Black Americans. And what was interesting, there's these publications study by the CDC that shows that the introduction of crack cocaine into the inner city coincided with a lot with a spread, significant spread of HIV/AIDS in the Black communities in the inner city, not only of Atlanta, but New York, Miami, Los Angeles, and so others. We also know that people living in these these projects or these segregated residential areas, women tend to have a extremely significant difference in terms of low birth weight and preterm birth deliveries. And, more importantly, the rates of more aggressive forms of, for example, cancer, breast, lungs is more prevalent because people tend to have a, more aggressive courses sometimes, but it's also a delayed diagnosis. And once they reach the healthcare system, may have a different outcome that if it's a different ethnic group, in this case, white Americans. So just to conceptualize these health inequalities, we talk about health inequalities, it could be health inequities as well. If you define these as the big circle here, a lot of the distribution of these outcomes, or, in this case, the risk of elevated or increased risk of death and some diseases among historically marginalized populations that have, again, a more aggressive course of the disease, premature death, and so on. And you try to explain, a big component here is the socioeconomic factors. But racism is part of that also equation, but it also has this independent influence that it's being measured in different studies. And again, we talk about the structural, cultural, individual discrimination, but of these three, the most important one is the structural. If we want to map this in a different way, the structural racism in the US, how does that affect health? It's basically, increasing a structural vulnerability to poor health. And one of the ways that we can assess that on a clinical encounter is by defining there's about 8 domains, and there's different, or at least there's one scale that we use, or a way to assess the structural vulnerability with 8 domains, which include housing, discrimination, food insecurity, employment, security, social network, and there's one more, but I'll mention it, I'll find it at the end, one of the slides. So that has to do with this aspect, but then also has to do directly with access to healthcare, insurance coverage, as well as the delivery of care, which has an impact, again, in the expression of these different clinical outcomes, as well as, having different degrees or different appreciation or perception of well-being among these communities. Some more specific examples, again, in this case, social vulnerability to poor health, in employment, housing, education, the criminal justice system, they all interact to affect in not only socially, but affect the ability of some of these populations to achieve, basically a health and well-being in a way that is comparable to other groups. The other one is access to care. Here, we know many hospitals, academic medical centers, and so on throughout the country that try to avoid money losing patients by different strategies, by having low, Medicaid caps acceptance, or refusing sometimes to see some particular populations. Locally, we have an issue where UC Health does not allow us to see, except for the infectious disease clinic, patients that come from the Immigration Detention Center or the 4 local jails for some reason that is not financial. The other example here is, poor delivery and quality of healthcare, which, that's more overall, there's an influence here of both structural racism as well as cultural racism, in which the way we sometimes treat different groups differently has an impact in terms of health outcomes. And one of the important things here is also the availability of, for example, there's one of the best stories is a randomized study of African-American men seeking healthcare. And then if they were with a race concordant physician, their outcomes in terms of cardiovascular outcomes were 19% better than if they were seen by non-concordant racial groups. So the ability to have the right or to this matching of having an African-American physician caring for an African-American patient as a preference does have an impact on clinical outcomes. So that's an important thing to say. And the reality is that the number of African-American physicians overall in the workforce in the US is not sufficient to meet these demands. The other example here is more also a combination of structural racism as well as individual discrimination, where there's studies that show that the risk of death related to, and there's different scales to measure discrimination. It affects accelerated age or accelerates age, causes strokes, and basically causes premature death overall if this is something that is perceived chronically. A good example of this is not patients, but individuals in prison, where we know, like, for example, in prison, if you are 55 years of age and you've been in prison for more than a year, your biological age is 65. And that's something accepted by even by the Justice Department as a reality. So when a recommendation comes, for example, regarding COVID-19, that the risk increases after age 65, basically that means in prison, like by record, somebody who's 55 years of age. So you have to adapt that to just to show you that degree of stress affecting aging in these particular populations. So we come to this graph and the studies that show that even if you, for improvements in other social factors, including income, education, and you adjust for them, there's a consistent gap between whites and blacks in the US and having a high rate of mortality. So there's a difference that is basically explained by structural racism that is not related specifically to income and education. So the three examples or the three cases I would like to run by you is the first one is a young kid, 19 years of age, that I met in a jail in Baltimore. During this pandemic, as mentioned earlier, I've collaborated with civil rights attorneys in performing inspections of many of the large jail systems in the US, and this is one of them. He's a gentleman from Baltimore. I was able to interview him, and we had a conversation. By this interview, also one of the medical students was with me, Jamie Solis, who did a wonderful job in also helping with some of the interviews. And during this interview, we talked about COVID-19 issues, but he expressed, his concern that mass incarceration of Black people was part of the, slavery phenomena. And, he told me also his older brother was killed in a drive-by shooting in Baltimore. Prior to incarceration, he was living with his mother and his little brother who's handicapped. He was currently incarcerated because of a parole violation from a previous incarceration for shoplifting at a gas station. And he was, at the point when I interviewed him, he was 11 months into incarceration because he could not afford $400 for bail. He was scheduled to be released in October, or he's scheduled to, so soon, hopefully soon, should be coming up soon. And he told me that he wanted to take care of his mother as well as his brother. So the question I would like to ask here or to explain is, what are the chances that he will be successful in achieving those goals? And to give you a number, I think the number that I will give you is about 50%. So this 50% is based on recidivism of reincarceration among this population of previous individuals incarcerated. Overall is 50%. In Colorado is a little lower, thanks to some of the efforts by the DOC and some community-based organizations in trying to promote basically better community reentry and reintegration. And here basically is just a structure diagram from that we discussed in this publication. Actually, was yesterday with Martin Kershak, with Andres, with Eric Pesla, with another colleagues in other institutions, trying to explain the benefits of decarceration of individuals like Rodney here. Use his name, but don't say more than that. But because I think it's important to understand these, these mass incarceration, incarceration in the U.S. follows these structures of oppression that in the Black community, goes back to slavery, lynching, segregation, and having this criminal justice system that is basically a legal lynching of many of these populations that manifests also in terms of police brutality, social discrimination. For the Native American nation, the decimation as well as the segregation they suffer also translate at the end of the day in having not only social inequities, but these are also health inequities that we discuss. They come together because health is such a very important issue of social equity. And then, not to, talk about the four major groups here, Latinx, basically the big problem is the discrimination as well as the immigration detention process, which we'll talk in a second as well. And the white community. In the white community, there's a phenomenon called deaths of despair that we'll also touch base, but it's part of this system of oppression in many ways by the hyper-capitalist system that we currently have in the US. So briefly, the criminal justice system, is basically the population. The US has about 2.2 million people incarcerated, and having 5% of the world's population has 25% of the world's prisoners. So that tells you that there's something different in this country compared to other countries. Secondly, the number of people that go through this revolving door, I use 400,000 to 500,000 to be conservative, but these numbers may be up to 700,000 every year. And the other thing that is important to talk about here is the fact that most of these incarcerations are in Black men. And if you take the overall Black community in the US, which is about 12% of the population, that represents about 40 to 45% of the number of people in jails and prisons in the US. So the structural racism in the criminal justice system does affect health, and that's the point that we're trying to discuss here. And it affects the individual, affects the family, and affects the children. The rate of mental health issues in the family, in children is very significant, with having about 2 million children in the US having a parent in jail or prison at any given time. There's another statistic here, which is about 50% of men, Black men without a high school degree are incarcerated at some point in their lifetime. And the issue that affects these communities has to do with, obviously poor medical care in jails, the consequences of being incarcerated, and also the fact that a lot of the social factors that occur in the community are also shared within the criminal, within these correctional facilities. So then when they're released, the first 2 weeks is a crucial, period of time where we tend to see a higher mortality in this population, as well as, other problems later on down the road. So community reentry is particularly important to make sure that these individuals are able to follow up, have a transition clinics, which there's one at Denver Health, and Megan Robbins here in the ID clinic, along with Martin Kershak, as well as Brian Montague and myself, trying to develop a project here to be able to provide care for people in transition to make sure that we meet their medical needs. Secondly here, the UCLA Behind the Bars COVID-19 data project, which is a much better system of data collection than the CDC or any public health department in the US to collect data about incarcerations. And COVID-19 shows that if you look at this graph by Sharon Dolovich, which is the director of this project, shows that the risk of the number of COVID infections in the prison population is proportionally different than in the US population overall. And these, as of a few days ago, when I was preparing this talk, there's about 131 cases with 996 deaths, and these are for correctional officers, which is not is also very significant. This is important to tell you and to understand that this is despite the fact that there is significant deliberate under-testing of people in these facilities, and that's of the 9 facilities, 7 of the 13 facilities that I inspected, along with other colleagues like Martin as well as Brian. Some of them, we know like there's an outbreak, and we know there's an outbreak because of the symptoms that some of the people that we interview, but there was an effort, a deliberate effort not to do testing. So part of the recommendations that we usually recommend after developing reports for these inspections is to do testing. So that way you do your population management, and by reducing your population number in jails, which basically, as you can see here, before COVID-19 pandemic, we did this analysis putting different data, is that we were able to achieve these numbers, about 10% of release. The second case, wanted to move a little faster here, is a 42-year-old man with a history of substance abuse to meth and opioids. He drinks heavily, and we saw him as a consultation for the management of HIV. He was admitted with a loculated, with an empyema, and he does have a history of chronic liver disease and heart failure. His social history is separated, has 2 children, and he has difficulty finding a job. He's Caucasian, and here what I would like to talk to you briefly is about these deaths of despair that happen in the white middle-aged population in the U.S. So this is based a lot on the research by Angus Deaton and Ann Hall at Princeton, the 2 economists that Angus Deaton is a Nobel Prize based on these studies, is basically to show that in the US, the high cost associated with employment-based insurance has defined these low wages jobs and people losing their employment or losing the wages. At the same time, with a weakening of the labor unions and gaining on capital by these corporate institutions, and creating a situation that is not necessarily just caused by poverty, but it's also this existential crisis with family dissolution, people lose meaning, lack of social cohesion, and leading into basically these important deaths. So if you look at these numbers from 1890 all the way to 2020, you see that there was an increase in alcohol-related deaths, suicide, and overall deaths associated with drug overdose also during the depression years. But we see that since the year 2000, these numbers have not gone up. Some of these may have to do also with globalization and automation and factories and this post-industrial era in the US. But the difference with this post-industrial area that is shared by other countries in other developed countries or high-income countries is that the healthcare system is very unique in the US. So the difference that they measure actually is that is globalization, is automation, but the cost of healthcare in the US is what drives a lot of these issues. And the connection here is basically that the medical manifestations of these may have to do with chronic pain, chronic stress or worse stress, substance abuse, mental disorders, leading to different diseases that we see, I would say, in the infectious disease service and the hospitality service frequently, cirrhosis, necrotizing pancreatitis, bacterial endocarditis associated with IV drug use and others. But if you look at these compared to other countries, as we were discussing, you find that these, if you compare here the expenditure per capita with life expectancy, you see that in the US, life expectancy is far away from other developed or high-income countries. And more importantly, you will expect this number to continue to rise here, but it's actually plateaued and even going down in the sense that this is caused by these deaths of despair, which is basically alcoholic liver disease, suicide, and drug overdose. So that's the white community in the inner city, and a lot that explains probably a lot of the politics in the country, but medically it does affect many of the populations that we care for. And the last case is basically one of the, doing this work also in immigration detention centers, in working with wonderful civil rights attorneys, we see that there's many cases of women, men, families in detention. And what I think is important here about this woman, and I'll tell you briefly, she's a 41-year female, and this is a real case too, with 3 children who's detained by ICE while picking up her children from school in California. She's not allowed to take her children home. And, she's basically been in detention for about 4 or 5 months now, not able to see her children. Basically, the neighbor is currently taking care of her children. She has no social support. And during detention, despite her efforts to shield from the COVID-19 pandemic, she acquired infection. She has lost about 15 pounds, suffering on a daily basis from intermittent episodes of palpitations, headaches, and panic attacks. She also has uncontrolled hypertension after taking atenolol during this detention. But this, by reviewing her records, she's clearly not under control. So she's struggling in there, obviously. So the chances is, what are her chances to be able to achieve asylum or be able to stay in the country to care for her children or to be deported? And the answer is difficult, but, we live in an era where we have to understand that this is a country of migrants, except for the Native American groups. And one of the important things to tell you here is the for-profit model that 80% of immigration detention centers are privately owned, and for every person that is in these detention centers, it's about $400 a day. So it comes to about $4 to $5 billion per year. And these same groups that push for these I would say, cruel for-profit business, is that they also are responsible for promoting a lot of the caravans in Central America by going to this country and providing false information about immigration reform. They also have a very strong lobbyist apparatus to block immigration reform from happening. So, this is basically a for-profit industry that, profits on cruelty. And there's medical consequences of these. Many of these people do have already underlying chronic conditions. They acquire some of them, as we discussed with this lady, this patient or this individual in California, by developing, basically severe or uncontrolled hypertension, depression, post-traumatic stress disorder, and a degree of anxiety that is clearly affecting her wellness in a very severe way. And she, illnesses during detention, there's cases of influenza, many deaths associated with influenza during past few years, during outbreaks of influenza in some of these detention centers, and the impact of the COVID-19 pandemic. So why is the poor care in these centers? Is these centers are understaffed, they're poor nutritional diets. Interestingly, all these centers have failed consistently these inspections by the ICE office, but not much has happened. I think up until now, there's one physician at the Aurora Center, which we have great communication. We have one before, through our colleague, superstar Megan Robbins, that was able to help us provide, some of the care for these populations. But now there's one guy, Dr. Zach, who we have a really good relationship, and we've been able to have a communication, at least by phone, at this point in time. The issue of translation is very significant, and there's, for a population that at some point was 1,500, the Aurora detention here is the second largest detention center in the US, had only one psychiatrist for 1,500 people, and one physician that was there only 3 times a week. So also, many of these people die during detention, and there's important, publications about these by particularly ACLU, of people who die from influenza, from cardiovascular events, and most importantly from suicide inside these detention centers, precipitated a lot by the anxiety, depression, and post-traumatic stress disorder. And one important thing, if you see this, I think it's a very striking number. Out of 21,000 detainees recently, 6,154 have been tested positive for COVID-19, and there's 8 deaths. But if you look at these deaths, I'm not going to go into more controversial issues. The reports, they're actually more than 8, but officially there are 8 deaths associated with COVID-19, and some people that honestly didn't have to be in there to acquire COVID-19 they could have been easily followed out in a community, or simply could have been deported earlier and not kept for such a long period of time. So just to tell you that, there's asylum seekers, refugees, immigrants, and there's different ways. And if you feel like sometimes you care for a patient that requires immigration assistance, there's different immigration attorneys in the Colorado area that provide pro bono effort. You can always contact me, Megan, or one of the ID attendings, and we'll be happy to give you some guidance on who to contact. For example, the U visa for somebody who has suffered sex trafficking. There are ways to help these people from the medical perspective that if we're aware of, we can help them achieve their immigration status corrected. So the other thing what we can do, we've done these different, I would say, advocacy by writing op-eds and working with different community groups, immigration reform groups in the country. And one of the things with different immigration detention physicians or people who work also in trying to release people from detention is we wrote these, I would say, back in May, June, predicting that it was going to be a problem because we know that compared even to correctional facilities, jails and prisons, medical care is extremely poor and the resources are really, very different than jails and prisons, which they're already pretty bad. But the difference here is that the medical care is extremely poor in these centers, and that's, not anyone's opinion, that's a proven fact. So just to show you that 30% of them acquire is very important. So just to finalize the last 2 minutes is, clinical medicine is an incomplete endeavor, in my opinion, in my journey, and wanted to share in these grand rounds. If we don't pay attention to societal forces, we can definitely do more. There is no question in my mind that, and in my experience and learning from all my colleagues and from students, that we need to improve our basically structural competence. And when we do our social assessment, social history, we need to talk about, food insecurity, housing, employment, legal aspects, discrimination. And we do this in a class at the School of Medicine, at least that we started last year, where we have students do structural vulnerability assessments to be able to develop what is called a structural differential, because our traditional model here is that we care for illnesses in the hospital, but the ideal process is to basically move really to improve social conditions, or at least fight for them, fight against structural racism and countering some of these inequities. And we know that like in the history, like this is data from Thomas McEwen in the UK, that by improving social conditions, the longevity in the UK has improved, and then this graph is very similar to the US. And the impact of modern medical care is important, but it's not huge compared to what we can do in the community. So if you attack health inequities by promoting well-being, by addressing these issues, we can overcome some of the concerns or challenges of having a fragmented healthcare system in just repair shops, in clinics and hospitals. So the model that, working with Erin Brolick, one of the students, and other students too, is that we come up with these sort of like graph where, we have to take care of people the way we do, but we also have to think about how we incorporate these structural vulnerabilities, structural differential, and try to implement some of these. So, a person who's an IV drug user, we need to look at other factors, including addiction, depression, community. Once we release them, what are we going to do to be able to in a way, promote their well-being by able to recover their children from foster care, find an employment, what else can we do for them? And as well as also the fact that, we have to go out there to the community and advocate for some of these social improvements, because as we discussed, disease happens in society, and we need to understand this better. And just to find out, this is the moral determinants of health by Don Berwick in JAMA, just to talk about, to think about, making health as a human right, the realization that, we need to address climate change, compassionate immigration reform, the criminal justice reform system is important and address hunger. 40 million children are hungry in the US today. And homelessness too, which is huge and a growing concern. For this, the pipeline in healthcare, we need to favor, and I know many medical schools are doing efforts, but probably not enough at this point to improve the proportion of minority healthcare workers. Reimagining the doctor-patient relationship by trying to deal with our biases as much as we can and being able to provide better healthcare. And finally, we had to push ourselves to go the extra mile for improving the care that we provide patients by understanding these larger societal factors and for societal change. And I'll finish there. And just to thank everyone that I have learned from, particularly Janine Young, Jamie, Trina at Denver Health, Michelle Haas, Eric, my boss. In the community, all these nice people, particularly Hassan Latif, Megan Robbins, the superhero in the division, and many of my other good colleagues, Martin Kershak. And, John Schultz, Greg, Dave, Lillian, we talk about these issues, hope to reach the other fellows to talk about these important goals. And then medical students, all of them, they're all wonderful people, particularly Aaron, Jamie, Taylor, William, Jessica, Andrew, Jenna, Marisa, and Jessica. So thank you, everyone. And I hope if we have some time, sorry, David, that I went a little bit more than I was planning, but I think we have a few minutes for questions.
Yeah, Carlos, this was really fantastic and an incredibly timely discussion that helped us see this from several vantage points. There are a number of questions I want to get to. Some I'm not going to be able to. But let me just start off with this first big question, which is, in the US and in many developed countries, we tie good employment to good insurance, health insurance. How does this affect the problem? How does this exacerbate the problem? And how might changes in the Affordable Care Act affect the problem?
Yeah, so I mean, this discussion, we had this discussion recently with Mark Levine, also wonderful learning opportunity with him. And basically, yes, so I mean, I think one of the thing that, we benefit, or I benefit, is from having this employment-based insurance, but it creates differences in society. And we know that, the ACA has addressed some of these potential or reducing some of these employment-based insurance inequities, or inequities that generate this policy, but it's not enough. And I think that's, hopefully we'll see some differences, hopefully with a different election outcome in November. But the thing that we know, as we discussed, is the issue of how this employment insurance base leaves many people out there without protection, and it creates this inequity. And just going to, for example, the white middle-aged community that we talk about, this weakening of labor unions, weakening of low wages, unemployment. I mean, there is an epidemic of despair caused by these, and it's not necessarily, poverty per se, but it's more the existential aspect of that. And a big component of that is honestly reading the book and so like doing a deep analysis of these, is that the cost of healthcare is really the problem that is behind all these. And the cost of healthcare in general require, making these health insurance premiums so high is one of the problems, David, that I think these people, these economists map to say this is basically the cancer in the US economy compared to other developed countries, as pointed out in the question. Because, globalization as well as automation and has not coincided with lower wages in these countries, but it's only in the US. And this is driven by the cost of employment health insurance. So if you're not, basically, if you don't have a college degree, or you only have a high school degree, and you're white, middle-aged American, in the community without being in the, big proportion of the wealthiest, which is, by my belief, from the reading is close to 45% of the population, the white population in the U.S. that I'm describing, is a big problem, because then what happens is that you are unable to, if you find a job, you will have a low wage job without benefits, that's one. The other thing is that, there's no chance for you to move. The social mobility does not allow you to move up anywhere because, again, there's no opportunities for jobs. So the healthcare and these high employment-based insurance policies are the ones causing a lot of the crisis in the U.S. By imposing, basically who has a good job and who doesn't have a good job. And again, it's something that has to be addressed. And again, for policy perspective, I know that Mark Levine talks about some of these organizations trying to address these at a more systemic level, but I don't know the specific details about that, but hopefully that will be included with a new administration, hopefully in November, David.
So, Carlos, thank you. So I've heard a lot of a substantial amount of pushback with the concept that race is a social construct as opposed to a biological reality. And as I think about it, I think that it stems from a lot of the research that shows that there are genetic variants that are that define ancestry. So could you, for the audience, distinguish between ancestry and race and talk about the evolution of race as a social construct?
Yes, so the in this case, I think definitely in this case the theories, particularly during the early 20th century with the eugenics movement, about that there were some races or some ethnic groups, and in this case, ethnicity defined as a particular group that had similar phenotype, who also shared same cultures and same languages, for example. So, for example, in this case, ethnicity would be somebody who's Arab. The Arab countries may be different compared to maybe somebody who's Jewish, for example. So we know that there's, as you know, and you're the expert here, Dave, this ancestry does define, this ancestry, these genetic basis of our previous experiences of our ancestors, what they've gone through, does impact some of the distribution and clinical outcomes of some diseases. But I think for the most part, the concept of race, as you said, is a social construct in the sense that we know that, for example, if you compare in this case, race as somebody who's phenotypically, in this case, Black American, has a different set of genes that predispose them to, for example, have a worse outcome associated with COVID-19. Although the research is ongoing, and I think we ought to continue to have an open mind about potential biological explanations of these. For example, it could be, just to be very specific, that the expression of the tryptases, the TMPS S2, which is the tryptase that is responsible for cleaving the spike protein in the case of coronavirus, or in influenza, we know that influenza matters. So there is a biological component there where if you have a higher expression of these tryptase clara that activates the hemagglutinin, you will have a better adhesion of the influenza virus to the respiratory epithelium, and that correlates with more severe disease as it happened in the 1918-1919 pandemic. There are some potential biological differences that express the, I would say, in that case, the severity of the disease, as well as the increased mortality. So going back to the COVID-19 example, what I wanted to bring that question is to the fact that there may be some in our ancestry that explains that maybe there is some potential differential expression of these TMPSS2 maybe in the nasal mucosa or in the oropharynx, or even maybe in the respiratory epithelium that I believe there's some at least a couple of publications in this regard that may explain the ability of the virus, once you're exposed to it, to be able to adhere to the ACE receptor and have a more severe clinical course. So that may be true also, but in this sense, what I refer here is that we know that, for example, Latino as a race or Blacks, they tend to be, those that have housing issues, they tend to have more overcrowding. They have to work on a daily basis, particularly in the service industry. So in this case, say race is a social construct because it has to do with social factors. And these factors are the one driving, in this particular instance, the increased exposure to the virus or increased risk to being exposed to the virus and becoming ill. And if you take, for example, the case of Latinos, the problem goes further because of this public charge issue where if they are trying to look for having a legal path to documentation to stay in the country, they're afraid because they know that if they are, they reach the medical, they may have Medicaid, but they're not using it. But if they reach the medical care system or healthcare system, excuse me, that they may be now, detected by the system and they may impair their ability to achieve that legal status in some way. So that's why, I wanted to explain this from a social perspective. That explains the distribution of this disease that is not necessarily related to the ancestry, but more to the social construct. But it may be too that, as we know, that some of these guys do come late, and that may explain a lot of these, but that there's still space for some, ancestry or basically genetic experiences of the past that explains maybe a potentially different distribution of these tryptases. And we ought to keep our mind open to that possibility. But a lot of the disease, the burden of disease, we should recognize that is based on the social construct of race, in this case for Latinos manifesting and Black Americans as well.
Carlos, this has been a great discussion, and we have many more questions, but we don't have enough time. So I'm going to apologize to you, but thank you very much for raising this issue, discussing it with us, and educating all of us.
Thank you so much, Dave. Thank you very much, Dave.